Good morning. This is part 2 of AI in healthcare. Now, as an educator, I've found many times students are not just curious, but they also want to know what exactly is the real world clinical applications. Now, where is AI actually working in our clinics and hospitals right now? Very valid question. Now, you would have heard about it in retinal screenings, in chest X-ray for TB and lung cancer, workflows which have been deployed in major hospitals, they have improved. You can predict ICU readmission, intra-bowel perfusion, flap perfusion can be made out, and skin lesions with detection with AI apps. In fact, there is one of our students who had presented a research article, and I will show you exactly how we have applied it. Now, let's move on. The first thing is your retinal. In fact, AI in ophthalmology was one of the first to be deployed. So, have a look. This is your fundus. Please don't rush through the slides. There is a lot of text there. I will take you through. This is your fundus examination, and this is not normal. There are exudates and hemorrhages which have been found. Now, when you enable an AI, you've got AI enabled views. This is called computer vision. There are special software to even look at a normal retinal scan generated, or in other applications, even the camera in your smartphone can be taken, photograph can be taken, and an AI software is placed on this layer, and you're able to get better outputs. So these are AI-enabled views. You can see even inside those obvious lesions, there are big patches of red and yellow. So this is confirming that the situation is larger than this. And not only that, it will help the clinician to focus here. For example, this lesion was never available to the naked eye, but here it has been picked up. This is, and these are the gray maps. So these are called heat maps. Let's not go into the technicalities. So now what happened? All patients who were flagged, please don't run down the algorithm. There is a lot of trade-offs there. I'll come one by one. All patients flagged as having referable diabetic retinopathy by AI, whether true or false positive, doesn't matter. They are ultimately referred to an ophthalmologist for confirmation and further management. You need the subject matter experts for confirmation itself. Then they will decide what to do with the confirmation. Now, triage and confirmation, ophthalmologists will review, confirm, or refute the AI's finding. Now, if your AI is flagging 100 cases, 50% will be true positives because the ophthalmologist has seen it and decided this is true positive. Another 50% which the AI has generated will be again, they don't know it's false positive yet till your ophthalmologist will look into it and say this is false positive. Now, when you say, I have a system which is diagnosing 50% right, yes, but for that I have to do an equal number of screening. Now, where are we as far as public health and costing matters? Now, these false positives, what do they do with them? They are reassured and managed for other incidental findings. Your question again, 50% is a big overload to take care of this 50% who have a problem. Naturally, it will increase burden on the specialist, but they can pick up other findings. Number one, it's a small trade-off. Now, this 50% over positive, false positive, is acceptable in public health. Missing true cases is more dangerous than over referring, as untreated diabetic retinopathy can lead to irreversible damage. Okay, now coming to the exact role of AI in ophthalm. In laser refractive surgery, yes, it has highly individualized treatments can be offered. This has got a high adoption rate, very important. Very high adoption rates have started coming in for this particular surgery. AI is really helping so that it is not one size fits all. Now, if you look at corneal surgery, it has got limited clinical use, but promising recent studies are coming out. Coming to retinal and vitreoretinal, you have moderate adoption rates in specialized centers. So if you know exactly what is going on right now, it helps you to get a better grip on the AI. Now, ultimately, because of all these studies, plus India has contributed a lot to this AI in diabetic retinopathy from various centers, especially Arvind Eye Hospital, the government itself has said, yes, let's use it. It has given, the regulators have given the nod to be used in the public health space. So now look at the chest CT. This is a okay CT, you can't pick up, it looks normal, but then when you had a heat map, you can find out that there is a real lesion there. And once you get the lesion, you will decide how best to sample it, either through a transthoracic or through a bronchoscope. Or again, your AI might help in doing the process of bronchoscopy and hitting the target. So now this is the Cure AI. As I told you, in India, you wanted to know what's going on. They are the leaders in interpretation of chest X-ray. And believe me, chest X-ray not for anything in the chest X-ray. It's very specific. One for TB and the other one for cancer lung. Now, the idea is this chest X-ray is not the end all, that it's not going to see the end of the radiologist. It is going to diagnose only two things. One is TB, the other one is cancer lung. And this was deployed in the Kumbh Mela to screen for TB. So these are things where you can deploy in large areas. You know the burden of TB. I'm not going into the public health part. Now, we keep on telling, will AI replace doctors? And that too, the first ones, the Bakras, they'll keep telling, is it going to replace radiologists? No. If you really look at it, your AI may be answering very few, maybe doing very few tasks as what a radiologist will do. They will have absolutely, maybe maximum they have gone into the communication tool, whether they can go there and talk to patients. A whole lot of other issues are there. So if you really look at it, they are only sitting in some places of a radiologist's tasks. Okay, coming to breast cancer screening, another AI deployed, that is by Niramai. Now the sensitivity is quite a bit, it's 90%. Plus, not only that, it can be deployed in even dense breasts and there is no radiation. It can be deployed even in your offices. They are going and taking it and deploying it even in the offices. It is no touch. If you see, it's a thermal camera. The AI now, traditionally, this was available. It's not that it's come in now. Traditionally, this was manually evaluated. A radiologist was manually evaluating. Now they have used AI as a software here and they are able to pick up smaller lesions which could have been missed. This is from Microsoft. You can see that false positive rates have come down, predictive rates are improved, and this is 92% that is alignment with expert radiologist annotations. Now it is built on anomaly detection and explainability. This model enhances, not replaces clinical workflows. Triages, minimizes unnecessary follow-ups. It has been trained on 9,000 real-world MRIs. Now have a look. AI was deployed in the Tata Memorial Hospital, a hospital with a very large volume of workload. They deployed it in a particular department. They found a lot of clinical benefits. They deployed the AI into the CT scans itself, and they found out there was a reduction of 40% reduction in pediatric CT scans. They did not need it. 96% in AI assisted radiology. Time to diagnosis, immediate results, faster workflow, because for the report generation itself, they used AI. And then avoidance of unnecessary chemotherapy, they used genomics and decided this subset of patients have the same cancer, but they don't need chemotherapy. Now they had a bioimaging. The fallout was they also got some data volume. Patient outcome tracking was very important. Otherwise, individually you have to track, or you have to probably use lesser, simpler models which will not be able to track big data. Their volume is quite big. They were able to track them. Naturally, when you do these things, your operational efficiency will go up. Now, interactive case scenarios. Case number one, AI says no MI, ECG looks normal, but patient is diaphoretic. Would you override the AI? Why? This slide sparks discussion on clinical thinking and AI trust. Now, everything is normal. Now, in day-to-day life, even when we did not have an AI, when patient has chest pain, there is no MI, ECG looks normal, we still were observing him and probably doing serial ECGs and markers. More so when AI has come and said, no MI, please don't accept it. Not only that, you got a nice clinical finding here as patient is diaphoretic. You don't need anything more to overwrite this AI. Now, sometimes you will not even have this clinical clue, or you will miss this clinical clue. Then when AI says there is no MI, you would not discharge. So any doubt you have, you be careful. This is ethical use of AI. So if you realize your training, your practical apprenticeship, and your training in your clinics, in your theory classes, and in your real life, they cannot be substituted by AI. Simple clues which are available and which you are aware are very, very helpful. So when you are in doubt, override AI. This is very important, and try to get a human in the loop, which may be your colleague, maybe your junior, or maybe your senior, depending on the hierarchical organizations. Now, just an example. I have put this picture. This is a still picture. It is not even a video. Now you can put a video into Notebook LM. That time we didn't have Notebook LM. I put it in ChatGPT, which should accept only still pictures, and asked, can you analyze the gait and give the full fall risk score? Now we all know there is a fall risk. You have to calculate it and a whole lot of things. Let's see what AI has done. It has analyzed this picture by saying this is a lady, she's got a bandage, and she's trying to get down on her walker. This is a very important step, most prone for falls. When they are walking, they don't, but when they get down to the walker, they are prone. So this activity is prone for falls. And it has also looked that it has no footwear there. It has diagnosed this patient has got a surgery done. Now, after analyzing, it has thrown up the risk score. Let us not go into the details, but it has thrown up a score. And it tells you what exactly is the score, and not only how it came with that score. This is important. Explainability in an AI is important. Otherwise, you will not trust it. And then finally, it also gives you suggested precautions. This is very important. It's natural. You have to clear the path. It has to be supervised, physiotherapy and rehab support, and a whole lot of other ancillary stuff. But most important, it drew your attention to pain management, as pain will affect gait. Now, this pain need not be at the stump. It could be even at the IV line. You see how a subject matter expert is able to tease out the pain management. That is where your role comes in. Your critical thinking will come in. It could be pain in the hip. It could be pain where the spinal was given. She could be having a headache because of post-spinal headache. All this a subject matter expert. You see, the moment it gave a lead saying pain management, you started thinking in all directions. This is where a subject matter expert will enter the AI cycle. Now let's have another look. This was a patient who was part of the research program. Somebody had presented. They were using bleomycin for whether the warts were disappearing. There were viral warts after applying the bleomycin. This was there. This is before and this is after photograph. Now what has happened? The same photograph, we put it into a AI, into an LLM, and what did we get? Yes, it is showing areas of healing, yes, but you can find the center is still hot. This you can probably assume because pathology will be lurking in the center, no big deal. But what threw off was another patch on the left toe, on the second toe, which was not available because this is a brown skinned man at a first glance. So with the AI, we did go and look at this toe and we did find difference. Now your naked eye will be able to pick up the difference. So what exactly has happened? Noteworthy is this lesion on the second toe. Now, coming to another scene, we had acute cholecystitis in pregnancy. The flow chart, if AI can generate, you can ask exactly what to do with her. It will give you a nice flow chart that we know. We had to tide over this acute attack and take her up for an elective surgery during the second trimester. Now, when we take up for second trimester, the chances of a preterm labor is also there. Of course, you're going to use your precautions. But if it does happen, then the baby needs to be in the NICU. So when we explain to the patient that the NICU cost may be much more than the laparoscopic cholecystectomy cost, she showed apprehension. She said, I cannot afford. What do I do? Now we knew of only one scheme, that was a chief minister's scheme. So we put this prompt into the AI and asked for the clinical algorithm as well as, can you tell us the government schemes that this particular patient with this particular problem can avail of? And she's from Tamil Nadu. It threw up a whole lot of government schemes which we were not aware of. Government has deployed these schemes, but some are very difficult for us to keep up with. All the knowledge, including the administrators in our hospital, will not be aware of. So now, every time, who's accountable for this AI intrusion? Everybody says it's the doctor. Now, it was the doctor some time back when things were in the lab works or in the back end. Slowly, the role of clinician started getting smaller, a relief for us, because they were insisting that the deployers or the uh, product managers or the administrators or the people who develop the products should have a 30% responsibility. That means they must have used stringent methods to do to make the model and to deploy it. And then finally, they have a big share of about 50% responsibility. Otherwise, the clinician was left with this, and naturally, there will be a lot of apprehension to trust an AI. Now, what are the ethical dilemmas? All the time we talk about ethics. Now, ethics is not just privacy. Yes, Patients have a right to their information. But then you can be doing harm itself to them, let alone exposing their data, which is worse, harming them. And how harm can occur because of bias in the training data. Your data was not spruced up well, or it was not inclusive, or black boxes. If you look how the algorithms work, sometimes they are so complex the tech guys themselves cannot understand it. But they do work, and when they were tested in real clinical scenarios, they were validated. So there is lack of transparency in deep learning models. One, because the model itself is too complex. You can see this in neural network. Or there may be a deliberate tweaking by the developers. Privacy, yes, and it has happened. It's not that it's going to happen. It has happened in larger scales in two incidents and smaller scales in other scattered instances. What can AI do and cannot do? It can spot patterns, assist triage, look at multiple factors like your age, BMI, a whole lot of things to predict surgical site infections, but it cannot show empathy and make context based ethical choices. Now, suppose AI has flagged cancer, but still you need the doctor's judgment for treatment. That, like as I told you, in the diabetic retinopathy.